Let me say something that's going to sound strange coming from someone in healthcare. More medical testing is not always better. In fact, for certain screenings, particularly once you're past 60, the testing itself can cause more harm than the condition it's designed to catch. And the medical establishment, to its credit, has been quietly reckoning with this for years. But that conversation hasn't made it out to most patients. Most people still operate under the assumption that if a test exists and their doctor offers it, getting it is always the right move. It isn't. Always. Now, let me be clear before we go any further, because I want you to hear this right. I'm not saying avoid doctors. I'm not saying modern medicine is some kind of conspiracy. I have enormous respect for what medicine can do, and there are screenings that absolutely save lives. Some of them, I'd argue, are non-negotiable past a certain age. But there are others, 5 of them specifically, where the evidence, when you actually look at it carefully, tells a more complicated story, where the false positive rates are high enough that a positive result is more likely to be wrong than right, where the follow-up procedures carry their own real risks, where studies have repeatedly failed to show that catching these things early actually changes outcomes, where the anxiety generated by an ambiguous result does measurable damage to quality of life, and sometimes leads people down a cascade of interventions they never needed. That's what we're talking about today. Not anti-medicine, not fear-mongering in the other direction. Just a clear-eyed look at 5 screenings that, if I'm being direct with you, I would personally decline, and why. There's a term in medicine that doesn't get nearly enough airtime in the average doctor's office. It's called overdiagnosis, and once you understand what it means, the way you think about medical testing will never quite be the same. Overdiagnosis doesn't mean a wrong diagnosis. It means finding something real, a genuine abnormality, that would never have caused you any harm if you'd never known about it. It would never have grown, never spread, never shortened your life. You would have lived out your full lifespan, died of something completely unrelated, and that abnormality would have gone to the grave with you, entirely silent. The problem is that medicine doesn't yet have a reliable way to tell those silent abnormalities apart from the dangerous ones, so when we find them, we treat them. And treatment carries risk. Surgery carries risk. Radiation carries risk. And perhaps most underappreciated, the psychological weight of a diagnosis, even one that turns out to be nothing, carries its own very real cost. Think about what happens when a screening test comes back with an abnormal result. Your doctor tells you something was flagged. Maybe it's probably nothing. Maybe it needs a follow-up scan. Maybe it needs a biopsy. And from that moment, you are a different person. You are someone waiting, worried, rearranging your life around appointments. That anxiety is not abstract. Research has shown it has measurable effects on sleep, on cardiovascular health, on immune function. The stress response triggered by a cancer scare, even a false one, is something your body responds to as though the threat is completely real. Now multiply that by a false positive rate of, depending on the test, anywhere from 20% to over 60%. Meaning for every 10 people who get flagged, potentially 6 of them are going through all of that for nothing. This is the calculus that most discussions of screening leave out. We talk about the lives saved. We don't talk nearly enough about the harm done to the much larger group of people who got a false alarm, went through procedures they didn't need, and came out the other side with anxiety, complications, or a diagnosis that changed how they saw themselves, all for a condition that was never going to hurt them. And this is what makes it especially relevant for the 60-plus audience specifically. As we get older, the prevalence of these silent abnormalities goes up significantly. A 70-year-old has a much higher chance of having something on a scan that looks concerning, flags as abnormal, and turns out to be completely benign than a 40-year-old does. Which means the older you get, the more likely a positive result is a false positive, and the more the risk-benefit calculation on certain screenings starts to shift. This isn't fringe thinking. The U.S. Preventive Services Task Force, the body that sets national screening guidelines, has been walking back recommendations on several of these tests for exactly these reasons. Major cancer organizations have updated their guidance. The evidence has moved, the recommendations have moved, but the conversations happening in exam rooms often haven't caught up yet. So with that framework in mind, let's get into the 5 specific screenings. Number 1, routine PSA testing for men over 70. The PSA test, prostate-specific antigen, measures a protein in the blood that can be elevated when there's prostate cancer present. Sounds straightforward. The problem is, it can also be elevated for about a dozen other reasons that have nothing to do with cancer: an enlarged prostate, a urinary tract infection, recent physical activity, even sexual activity in the days before the test. The result is a false positive rate that, depending on the cutoff used, can run well above 75% in older men. And a positive PSA result has a very predictable next step: a biopsy, which involves inserting needles into the prostate multiple times to sample tissue. That procedure carries real risks: infection, bleeding, and in a small but meaningful percentage of cases, serious complications requiring hospitalization. So right away, you have a test that's wrong more often than it's right, leading to a procedure that isn't without consequences. But here's where it gets more complicated. Even when PSA screening does detect real prostate cancer, the evidence that finding it early actually saves lives in men over 70 is genuinely weak. Prostate cancer in older men tends to be slow-growing. Most men diagnosed with it in their late 60s and 70s will die of something else entirely: heart disease, stroke, another illness, long before the prostate cancer would have caused them any symptoms. The cancer was real, but it was never going to be the thing that got them. The U.S. Preventive Services Task Force reviewed all of this and gives routine PSA screening in men 70 and older a grade D recommendation, meaning the evidence suggests the harms outweigh the benefits for this age group. That's not a close call. That's the evidence saying, for most men in this age bracket, this test does more damage than good. I see this pattern more than I'd like to. Someone gets a routine PSA, it comes back elevated, they go through a biopsy, the biopsy finds low-grade cancer, and suddenly they're facing a conversation about treatment, surgery, radiation, for something that, at their age and with their overall health, was almost certainly never going to shorten their life. But now they can't unknow it. And that changes everything. There are exceptions. Men with a strong family history of aggressive prostate cancer, men who are otherwise very healthy and would genuinely benefit from early detection, those conversations are worth having individually with your doctor. But routine, annual PSA testing as a default for all men past 70? The evidence says no. Number 2, routine resting EKG for low-risk, asymptomatic adults. This one surprises people. An electrocardiogram, a reading of your heart's electrical activity, feels like exactly the kind of precautionary thing you'd want. It's quick, painless, non-invasive. What could possibly be the argument against it? The argument is this: in people who have no cardiac symptoms and no significant risk factors, a routine resting EKG doesn't reliably detect conditions that would change their care. What it does do, with meaningful frequency, is produce abnormal findings that are either minor variations of normal or artifacts of the test itself. And those findings trigger follow-up. More tests, a stress test, an echocardiogram, sometimes a cardiology referral. A whole chain of events set in motion by something that wasn't a real problem to begin with. The USPSTF recommends against routine resting EKG screening in low-risk adults without symptoms, not because heart disease isn't serious, but because this particular test, used this way in this population, doesn't improve outcomes. It generates false alarms, and false alarms in cardiology are especially costly, not just financially, but in terms of the anxiety they produce and the downstream procedures they set off. Now, this is different from a diagnostic EKG, one ordered because you have chest pain, palpitations, shortness of breath, or a known cardiac condition. That's an entirely different situation and absolutely warranted. The concern is the reflexive, annual, let's just check EKG on someone with no symptoms and no particular risk. That test, the evidence says, is generating more noise than signal. This is where it's worth being honest about something. Defensive medicine is real. Ordering a test, even one the guidelines don't support, protects a doctor from the 1 in 1,000 scenario where something was missed. The incentive structure isn't designed around your individual risk-benefit equation. It's designed around liability and thoroughness. Understanding that helps you ask better questions when a test is recommended, not just, "Can we do this?" but, "What do we actually do with the result, and how does it change my care?" 2 down, 3 more to go, and the next one is probably the most controversial of all. Number 3. Thyroid cancer screening. Thyroid cancer screening, typically done via ultrasound of the neck, has become increasingly common as a kind of add-on to routine checkups or executive physicals. And on paper, catching thyroid cancer early sounds like exactly the right thing to do. But this is one of the most striking examples of overdiagnosis in modern medicine, and the data here is almost hard to believe when you first see it. Over the past 3 decades, the rate at which thyroid cancer is diagnosed has roughly tripled in the United States and in several other countries that increased their screening rates. You might expect that to be followed by a corresponding drop in deaths from thyroid cancer. That's how effective screening is supposed to work. You catch more, you treat more, fewer people die. The death rate from thyroid cancer barely moved. It was flat before the screening increase. It stayed flat after. What changed was the number of people diagnosed and treated for thyroid cancers that, in the vast majority of cases, would never have caused them any harm. An analysis published in the New England Journal of Medicine examined this pattern across multiple countries and reached a clear conclusion. The dramatic rise in thyroid cancer diagnoses represented overdiagnosis on a large scale, the detection of cancers that did not need to be found. The treatment for those cancers typically involves surgical removal of the thyroid, which means a lifetime of thyroid hormone replacement medication, and in some cases, permanent changes to voice, calcium regulation, and other functions. Real consequences for a cancer that was silently minding its own business, and almost certainly always would have. The particularly sobering part of this story is South Korea, which launched an aggressive national thyroid ultrasound screening program in the 1990s. Thyroid cancer diagnoses increased by more than 1,500%. The death rate didn't change. Eventually, South Korean physicians themselves began publicly calling for the program to be scaled back. That is an extraordinary thing, a medical community acknowledging en masse that a screening program was doing more harm than good. None of this means that symptomatic thyroid issues should be ignored. A lump you can feel, difficulty swallowing, voice changes, those warrant evaluation. The concern is the incidental, asymptomatic ultrasound sweep of the neck that finds small nodules that would never have been found otherwise and sets an entire treatment cascade in motion. Number 4. Whole-body CT scanning. This one has been marketed aggressively, often outside traditional medical settings, through private imaging clinics offering what they sometimes call peace-of-mind scans. The pitch is seductive, a full-body CT scan that looks at everything at once, early detection of anything that might be lurking. What could be more proactive? A lot, actually. A whole-body CT scan delivers a meaningful dose of radiation. Estimates suggest the radiation from a single full-body CT is equivalent to several hundred chest X-rays. For someone in their 60s or 70s getting these scans repeatedly, that radiation exposure is not trivial. It's an actual increased cancer risk, introduced by a test supposedly designed to protect you from cancer. The irony there is not subtle, but the radiation is almost the secondary concern. The bigger problem is what these scans find. When you image the entire body in fine detail, you find things. Lots of things. A small spot on the liver, a nodule on the lung, a shadow near the adrenal gland, an incidental finding on the kidney. These are called incidentalomas, incidental findings that weren't the target of the scan and, in the overwhelming majority of cases, represent nothing dangerous. Benign cysts, normal anatomical variations, age-related changes that have been there for decades. And I want you to really feel what this experience is actually like, because the clinical description doesn't capture it. You go in for your scan feeling fine, healthy, maybe a little proactive, proud of yourself for taking charge of your health. A week later, your doctor calls and says they found something on your liver. Probably nothing. But we should do a follow-up MRI to be sure. So now you wait 2 weeks for the MRI appointment. 2 weeks of lying awake at 3 in the morning, 2 weeks of Googling liver lesions and reading the worst-case scenarios first, the way we all do. The MRI comes back inconclusive. We should do a biopsy just to rule things out. Now you're having a procedure. The biopsy comes back benign. It's a simple cyst. It always was. 6 weeks of your life, real fear, real disruption. A procedure with its own small but real risk of complications. All to confirm what was true before you ever walked in for that scan, that you were fine. Multiply that experience across every person who goes through it. Research has found that a significant majority of whole-body CT scans in asymptomatic adults produce at least one finding that prompts further workup. Most of those findings turn out to be benign, but the workup happens regardless. The anxiety happens regardless. And for a meaningful percentage of people, the follow-up procedures result in complications from tests they never needed in the first place. Neither the American College of Radiology nor any major medical organization recommends whole-body CT scanning for routine screening in asymptomatic adults. Not because they don't care about early detection. Because the evidence says the harm profile of this test, used this way, is not justified by the outcomes. Your peace of mind is worth protecting, but a whole-body CT scan is one of the least reliable ways to get it. So with that, let's talk about the fifth screening, and then I want to leave you with something genuinely useful for navigating all of this. Number 5, carotid artery ultrasound in asymptomatic low-risk adults. Carotid artery screening uses ultrasound to look for narrowing in the arteries on either side of your neck, the ones that carry blood to your brain. The concern it's designed to detect is stenosis, a buildup of plaque that can, in severe cases, increase the risk of stroke. Again, on the surface, this sounds like exactly what you'd want to know. The U.S. Preventive Services Task Force gives this screening a Grade D recommendation in adults without symptoms and without significant cardiovascular risk factors. Same grade as PSA screening for men over 70. Harms outweigh benefits, and the reasoning is worth understanding, because it follows a pattern that by now should feel familiar. The vast majority of people screened will show either no narrowing or mild to moderate narrowing that doesn't require intervention, but a meaningful percentage will show findings that look significant enough to warrant further testing, or worse, surgical intervention. And carotid surgery carries real risk. A procedure called carotid endarterectomy, where a surgeon opens the artery to clear the plaque, has a complication rate that includes stroke and death. The very outcome the screening was trying to prevent can be caused by the treatment that follows the screening. When you run the numbers on large populations of asymptomatic low-risk adults, the math doesn't work in favor of routine screening. You expose many people to anxiety, follow-up testing, and potential surgical risk to potentially benefit a very small number. And even then, the evidence that intervention in asymptomatic mild to moderate stenosis changes long-term outcomes is weak. Now, and I want to be careful here because this is a genuinely important distinction, if you have symptoms, this changes completely. Sudden weakness on one side of the body, sudden vision changes, a transient episode where your face drooped or your speech slurred. These are warning signs that need immediate evaluation, and carotid imaging is absolutely part of that workup. If you have significant cardiovascular risk factors and your doctor recommends this test specifically because of your individual profile, that conversation is worth having seriously. The argument is against the reflexive, routine, let's just check sweep in people with no symptoms and no particular risk. That's 5. And what I want to leave you with is more useful than a list of tests to avoid. It's a way of thinking about any screening conversation you'll ever have. Mammograms save lives, colonoscopies save lives, blood pressure monitoring, cholesterol panels, blood glucose, eye exams for people with diabetes. These are not on this list for good reason. Some screenings have a genuinely compelling evidence base and a favorable risk-benefit profile. The goal isn't less medicine, it's the right medicine. What I want you to walk away with is a set of questions you can ask before agreeing to any screening. Not to be difficult, not to be the patient who refuses everything, but to be the patient who actually understands what they're signing up for. The first one is simple. What happens if this comes back abnormal? Walk me through the realistic next steps. Not the best case, the typical case. If there's a finding, what do we do, and what are the risks of that process? That question alone will tell you a great deal about whether this test is likely to help you or set off a chain of events you didn't bargain for. The second question gets at the heart of the overdiagnosis problem. How does catching this early actually change my care or my outcome? For some conditions, early detection genuinely changes what's possible. For others, the evidence that early treatment beats watchful waiting is thin. You deserve to know which one you're dealing with before you decide. And the third is about you specifically. What does my individual risk profile look like for this condition? Because most of the screenings we talked about today aren't problematic for everyone. They're problematic as blanket, one-size-fits-all recommendations applied regardless of who you actually are. Your history, your family history, your other health conditions, all of it matters. A good doctor will welcome these questions. They'll slow down and engage with them. That conversation is part of what good care looks like. You have spent your whole life being told to trust the system, to follow the protocol, to get the tests, take the pills, follow the schedule, and for much of medicine, that trust is well placed. But informed trust, trust based on actually understanding what a test can and can't tell you, what the risks are, and what the evidence actually shows, that's something different. That's you showing up as a partner in your own care, not just a recipient of it. That's the position you deserve to be in, and now you have the tools to get there. If this gave you something to think about, subscribe, and share this one with someone who needs to hear it. I'll see you in the next video.